Now, there are a number of neurological conditions where plasma exchange has been used, but a smaller number where there is actual established evidence. The biological rationale for use of plasma exchange in Guillain-Barre syndrome is to remove circulating antiganglioside antibodies and other neural antigens. There was a Cochrane review done in 2017 that found that plasma exchange was better than supportive therapy and most effective if started early, typically within 7 days, but it can be delivered up to 30 days. They didn't find any additional benefit of adding plasma exchange together with intravenous immunoglobulins, IVIG. What you use will be guided by your neurologist and your local practice, but typically ambulatory patients are started on IVIG, intravenous immunoglobulin. But if you have a patient who is rapidly progressing towards needing intubation and ventilation on the critical care unit, then plasma exchange will be the best thing to go for if you are able to. There are some cases where they may have had IVIG and yet they don't respond, they relapse. In these situations, plasma exchange can be used as a rescue therapy. However, it's really important to make sure that you've given a long enough period to see if they are going to respond to the IVIG before you start plasma exchange. Otherwise, you simply remove all the very expensive IgG that you have given. So plasma exchange has been used for myasthenic crises. There was another Cochrane review done earlier in 2002, and they found that the evidence was mixed. Some studies suggested that plasma exchange was better. Some suggested it should just be used as a rescue therapy. However, overall, it does seem that plasma exchange and intravenous immunoglobulin are equally effective. However, plasma exchange works quicker. So if you have a patient who is rapidly heading towards intubation and ventilation with a compromised airway and ventilation, then we would typically start them on plasma exchange rather than go through the intravenous immunoglobulin route. Again, with all these situations, you will be guided by your local expertise. So changing organ, how about renal conditions? The two main, forgive me. Let me go back to the prescription. I'm jumping ahead of myself here. I do apologise. How about the prescription for these neurological conditions? Well, for Guillain-Barre and for myasthenia, they're going to be very similar. For Guillain-Barre, it's going to be 1 plasma volume alternate days for a total of 5 exchanges. And for myasthenia gravis, again, 1 plasma volume daily or alternate days for 5 days. We tend to give the first 3 perhaps daily and then start to spread out the therapy, because what this does is it allows for redistribution of the proteins from the intra to extravascular space. In terms of replacement fluid, it's typically an albumin solution. But as I mentioned before, then you can use a combination of albumin and 0.9% saline. But again, as I said, no more than 50% saline. So now moving on to the kidneys, my favourite organ in the body. So there are 2 conditions that typically we use plasma exchange for: anti-glomerular basement membrane disease and ANCA-associated vasculitis. So firstly, ANCA-associated vasculitis. Now, ANCAs, anti-neutrophil cytoplasmic antibodies. These are autoantibodies against the cytoplasmic antigens in the primary granules of neutrophils and the lysosomes of monocytes. The initial screening test that we do simply identifies whether they're lighting up in a perinuclear, a P, or a cytoplasmic C pattern. You'll then need to go on and identify which antigen they're against. They'll typically be against myeloperoxidase or proteinase 3. When ANCAs bind to neutrophils, they lead to the release of toxic substances and the propagation of inflammation. So they're not only a marker of disease, but they're also pathogenic in their own right. Then there are anti-glomerular basement membrane antibodies. These are directly pathogenic autoantibodies that target the basement membrane of the lungs and the kidney. So why do they go for both of them? Well, they share a similar domain on type 4 collagen, which is why the kidneys and the lung are typically affected together. Is there any evidence for the use of plasma exchange in these conditions? Well, with anti-glomerular basement membrane disease, plasma exchange has been used since the 1970s. The evidence is really just case series or observational, but there's a good biological rationale for its use. And patients who are presenting needing renal replacement therapy, and particularly with pulmonary hemorrhage, for these patients, plasma exchange is a standard therapy. Up until recently, the recommendation for ANCA-associated vasculitis was that you use plasma exchange if you have an elevated serum creatinine, particularly if you're presenting with pulmonary hemorrhage. Last year, the results of the large PEXIVAS study were released, which showed no difference in outcome between using plasma exchange or using steroids when treating ANCA-associated vasculitis. The nephrology community are considering the way forward with this. So what I would say is that be guided by your local nephrologist as to whether you will still be delivering plasma exchange for this group of patients. How are we actually going to deliver this therapy for these patients? Well, for anti-glomerular basement membrane disease, the therapy is going to be 1 plasma volume daily for about 10 sessions spread over 14 days. Again, daily to start with, particularly if there is pulmonary hemorrhage, with the option to move to alternate days later on. For ANCA-associated vasculitis, again, 1 plasma volume exchange daily, but a shorter course, generally 7 over 10 to 14 days, but it does depend on the clinical picture. The replacement fluid, if you have pulmonary hemorrhage, typically you would use all plasma, but you do have the option to use albumin. And what you can do is you can give a pool of plasma at the end of therapy, particularly if you have got significant pulmonary hemorrhage or they're at higher risk of bleeding. So what about anticoagulation for all these conditions? Well, it will depend on how your local policy and your familiarity with the therapy. The options that we have regional citrate anticoagulation, we have heparin, or we can use nothing. We can have anticoagulation-free therapy. There is no evidence in plasma exchange that one therapy is better than another. So it really does come down to what you are familiar with and what your local policy is. If regional citrate anticoagulation is being used, then you need to be cautious regarding the citrate load if you are using a therapy that involves giving a large amount of plasma. If you're using heparin, then a higher dose may be needed to achieve the same effect because of the removal of antithrombin 3 through the therapy, through plasma exchange. So plasma exchange is not without its complications, and the complications can be related to the molecules that you're removing. We need large pores in our membrane to be able to remove the large molecular weight molecules. But we may also end up removing the large molecules that we want to keep. Good immunoglobulins, clotting factors, nutrients. Also remember that some drugs may be highly protein bound and they will also be removed. It's always important to refer to your critical care pharmacist or the textbooks to check on whether your drug is going to be removed. But in practice, most commonly used intensive care drugs are going to be fine. The complications that we may see may be related to the replacement fluid that we use. We need to watch out for hypocalcemia, particularly if we're using plasma with the citrate that's in it. We need to watch out for hypokalemia if we're using a large amount of albumin, which obviously doesn't contain any potassium. We may dilute clotting factors. And also remember, we are giving blood products. and there are all the associated risks and reactions associated with blood products. The complications may be related to the anticoagulation that we're using, whether that be heparin or citrate. And also remember, this is an extracorporeal system, and there'll be the complications that are related to that. The complications related to vascular access, to the fact that you are removing blood from a patient, passing through an extracorporeal circuit, and the risk of hypothermia and activation of the clotting cascade. All complications we need to be aware of, but we need to balance up the risks versus the benefits of actually giving this therapy to our underlying condition. So to summarize, there are a small group of patients that we will see on our intensive care unit that will need plasma exchange. Membrane plasma exchange is relatively straightforward to perform, and we are able to deliver it on our critical care units using some of the equipment that we will have already and that we'll be using to deliver renal replacement therapy to patients. Now, these patients can be very labour intensive, particularly if they need renal replacement therapy as well as plasma exchange. They can also be very costly, these patients. If you do have a patient that needs both renal replacement therapy and plasma exchange, and they're needing the plasma exchange daily, it's often just a case of trying to fit in both therapies. You need to watch for complications, but you need to understand the principles of the prescription. I've listed some of the prescriptions below on this slide, but what I would always say is refer to the experts. Protocols change and the evidence base is small, and there may well be local variation in practice. So thank you very much for listening, and I will take any questions a little bit later, but thank you.
Yeah, thank you, Dr. Sarah, for an excellent presentation and share your experience. I note that we have almost 200 attendees. So if there are any questions, please put it in the chat box and we'll cover them at the end of Dr. Deep's lecture. So I'd like to invite Dr. Deep to give his presentation on challenges in pediatric CKRT using the new terminology. Dr. Deep or Professor Deep, please.
Thank you very much, and a very good morning to all of you from a very sunny London today. So I'm going to talk to you about the challenges in pediatric continuous renal replacement therapy, which some of us have now started calling it continuous kidney replacement therapy. And for the purposes of this talk, I would be using consistently the word CRRT. So as John has very kindly introduced me, I work at King's College Hospital, which is a large tertiary hospital in South London, and I chair the critical care nephrology section of the European Society of Pediatric and Neonatal Intensive Care. So it's a privilege to speak to you guys. So let's start off by talking about the journey of critical care nephrology over the last few decades, from the 1970s to the 2000s. And you can see here that there has been a huge progress, whether it's to do with technology. And as the technology advanced, there were new modalities which came in. We started off with continuous arteriovenous hemofiltration. We then went to CVVH, CVHD, DF, and now we're talking of high volume hemofiltration. There have been new membranes, including the cytosorbents. And in pediatrics, we moved from the adapted era to the fitted era. And currently, we talk about the dedicated neonatal machines for continuous renal replacement therapy, whether it's to do with Carpedium, Aquadex, or Nidus. Sorry, going back. So in the next, say, 20-25 minutes, I'm going to talk about the challenges and practicalities of running CRRT in children, with a special emphasis of how vascular access, blood flow rates, the priming solutions, anticoagulation, quality markers vary depending upon the age, the size of the patient. This, I'm sure you are well familiar with. This is the patient's blood is brought to the filter, and then after a few therapies are done, which I'm going to talk to you about, the patient's blood is then returned back to the patient. If you are just removing the effluent, it becomes your ultrafiltration. If you have using convection as a modality, then it becomes hemofiltration. In convection, you can use the replacement fluid either pre-filter, it becomes a pre-filter CVBH. If you use it post-filter, it becomes post-filter. A number of times people use a combination of pre and post-filter replacement fluid, and it becomes pre or pre and post-filter CVBH. If you're doing dialysis, it is continuous veno-venous hemodialysis. And if you're using a combination of dialysis and replacement fluid, i.e. combination of dialysis and convection, it becomes CVBH-DF. So the most important thing is the basic principles to understand why and how things happen. And the most important aspects which dictate any modality prescription is why are we starting renal replacement therapy and what are we trying to achieve. This will dictate what we prescribe, and this will also lay the guidelines when to stop. So as I said, context does matter. The first question is why and how do we do things? What is our indication? Are we starting renal replacement therapy for renal indications, uremia, azotemia, fluid overload, or metabolic acidosis, or are we doing it for the bog standard hyperkalemia, which takes place in a patient who is critically unwell in an intensive care unit? But a number of times, a patient is started on renal replacement therapy for non-renal conditions, whether it is to do with the toxins and drug removal, it's to do with the metabolic complications, or it is to do with the control of temperature. A very important concept, at least at King's College Hospital, is to start renal replacement therapy early in a high dose in patients with acute liver failure for hyperammonemia and for high grade encephalopathy. And some people do use renal replacement therapy too as an immune modulator for sepsis, where they feel that removal of cytokines can help. So you can see that the indications will actually dictate when to start renal replacement therapy. The next question, continuing with the concept of context, is what are you trying to achieve? Are you removing the smaller size molecules like the creatinines and the ureas? Are you going to remove the middle molecules or albumin? Or as Dr. Blakely has said, are you going to remove the bigger size molecules, which means they will not be able to pass through the pore size, because what gets removed depends upon it on the molecular weight of the solute in question. It depends upon the saving coefficient of the membrane, and it depends upon the pore size. The hemofilter will not allow the large size immunoglobulins to pass through, and you need the plasma filter for that. Again, the next question you want to ask is when do you start renal replacement therapy, i.e. the timing of initiation of renal replacement therapy? And I think it depends upon a number of things. The very important thing is what is happening to your patient at that point in time. How stable is the patient? What is the patient's illness trajectory? Are you going to start the RRT very early, or are you going to wait for your diuretics to act? And sometimes it becomes an ethical debate. You can do doesn't mean you should do. If a patient has got multi-organ failure, has got underlying comorbidities, is it something you should be doing to your patient? And if you are trying to remove your fluid as an indication, is fluid removal an emergency or can it wait? The next is an operational question. Is this something we do often? And who are your stakeholders? Is it the critical care? Is it the nephrology? If you go to the US, you will see it's the nephrology guys who prescribe your CRRT. But if you come to Europe, especially United Kingdom, it is the pediatric intensive care colleagues, which is a doctor, a nurse, the bedside, and your CRRT nurses who run the show. And the next question is how do you assess your performance? Because whatever you do needs to have a quality marker. How do you say, or can you say that you run a good and efficient program for CRRT? Now, if you ask me the challenges for us as pediatricians, for us as pediatric intensivists, is the varying age, the varying size, and the varying weights of these patients, which means they've got varying physiology and they've got varying hemodynamics based on what the condition is. Because they've got different weights and they've got different sizes, which means they will also require varying sizes of your vascular. Classic example of one size definitely does not fit all in pediatrics. And you have to base your dose not on per kilogram per hour, but normally we weight on your body surface area. And thing which we have still not got control on is the unpredictable drug and nutrient removal, because your membrane is non-selective and it removes. the good as well as the bad. So the question is, can we have a typical prescription, i.e., can we say, this is the protocol, this is a prescription, use it for all patients, whether it's sepsis, it's liver failure, fluid overload? And the answer is no, because it will depend upon the underlying condition, and that will dictate also the dose. Do we know the dose which gives us the maximum clearance or increased survival? What kind of modality do we choose? Is it convection? Is it the diffusion, or is it a combination of convection and diffusion? Again, similar questions about the blood flow rate, anticoagulation, which one, when, what's the mode of delivery, and as I said, drug dosing and nutrition remains a perennial debate. Now, this slide takes you through the journey of a patient when we as a team decide that this particular patient is now going to go on CRRT. I think the first thing to have is a good teamwork, a team leader, which communicates very clearly to the team that we are going to start this patient on CRRT for this condition, whether it's AKI, it's fluid overload, it's hyperammonemia, because if you know why you are starting CRRT, you will be in a condition to stop CRRT as well. And at that point in time, we as a team start arranging for the pre-CRRT requirements, whether it's the blood products or keeping the fluids and vasopressors ready as these patients might decompensate. In the prescription comes your vascular access to have it in the right location and of the right size, hemofilters, priming solutions, your blood flows, your anticoagulations, and planning ahead. You need to plan ahead because that might reduce the risk. And we've got something known as the breach protocol, where we make sure that a patient goes on to CRRT in X number of time, which is X number of minutes or X number of hours. The thing which dictates, I would say, the success of pediatric CRRT is your vascular access. It could be technically really difficult. You've got a 2-kilo child who is very fluid overloaded and is coagulopathic, especially if the patient has got liver failure. How do you secure a vascular access? So a good quality vascular access of a good size in a good location will have an impact on the adequacy of therapy, because the blood flow rate will depend on it, filter life, and it also, of course, if your vascular access is not good, you'll have constant alarms going on and you'll have to troubleshoot more and more. And that's even more important during a pandemic, where you'll have to make sure that there's less contact with the healthcare professional with the patient. So this is just a slide showing you, depending upon the weight, what is the different catheter sizes which have been recommended. And you can say, even for a newborn, which is 2.5, 3 kilos, 2 kilos, the minimum we have done using a standard adult machine is about 1.6, 1.7 kilo child. And you can see that even in a newborn, it's about 7 French. It's normally not the bore or the caliber of the catheter which is a problem in pediatrics. It's the length of the catheters, because the minimum length we get is about 8 to 10 centimeters, and sometimes it hangs out of the neck, and that could be an infection issue, and that could be a kinking issue, which is a real problem in day-to-day practice. And this is a famous paper from Hackworth et al. From the prospective pediatric CRRT registry from the United States, where they looked at 376 patients from 13 institutes and used about 1,600 circuits, and they looked at circuit survival based on catheter size and the site. And you can see here that higher the catheter size, more catheters were functional at 48 hours. So 76% of 8 French catheters were functional at 48 hours versus 26% with 7 French catheters. And if you look at the filter life with the 5 French catheter, it was only 10 hours. So here is something where I would say size does matter, and bigger the size of the catheter, more is the filter life. And if you look at by location, you can see here that 60% of the catheters which were inserted in the internal jugular were functional at 60 hours versus 50% for subclavian femoral. So we choose a big sized catheter, try and achieve that with the shortest size, and put it in the right internal jugular, because it then nicely sets into the right atrium, which is the biggest reservoir of blood. Now, of course, I have given you one side of the coin, which is yes, size does matter, but it can come with its own set of complications. So this is a paper which has just will be published, I would say, in the next couple of months on the thromboembolic complications of vascular catheters for pediatric CRRT. And this is the editorial which I've written, which is going to come with this paper, large size vascular catheters in CRRT, balancing filter life with the risk of vascular thrombosis. But remember that if you occlude more than 50% of the vein size with the catheter, there will be more venous stasis around it, and there are risks of thromboembolism. And NICE does recommend that we should use ultrasound for putting in the catheters, but I think we need slightly more information about the catheter, i.e., what size before you put in the catheter, and a catheter to what you should aim for to prevent the venous thromboembolic. X-ray, you see this is the vascular access for dialysis, and this is your PICC line. And if you look at the tips of the PICC line and the tip of your vascular access for dialysis, very, very close to each other. And this is called the siphoning effect, because whatever you give, whether it's sedatives, whether you're giving inotropes, that might be siphoned out when your blood is siphoned out for dialysis. So what we try and do at King's is to put your dialysis catheter in the neck and have a central venous line in the groin if you have a child on all these therapies. So if I have to summarize the vascular access in pediatric CRRT, put in the largest and the shortest catheter when possible, prefer your internal jugular vein when the clinical situation allows, and avoid the central venous line and dialysis catheter in the IJV to avoid siphoning of drugs, and use of ultrasound to insert vascular access cannot be overemphasized, but make sure that the catheter to vessel ratio of 45% and below is achieved. And then we come to the hemofilter, and we all know they come in different sizes. And the bigger problem is of the priming volume of these hemofilters and of the sets. They can come with their own set of complications if we use AN69, for example, because that will lead to bradykinin release syndrome. Again, planning ahead when you know the patient is going to go on the on your CRRT, make sure you have everything there, your vascular access, whichever set you're going to choose, and choose it according to the hemodynamics and according to the size of the patient in question. Another debate which I think the adult colleagues don't face is, how are you going to prime the circuit? Are you going to use saline? Are you going to use heparinized saline, blood albumin, or albumin alone? And the reason I say this is because of this. If you look at it, this is a 4-kilo baby. The extracorporeal blood volume is about 80 mils per kilo, which is a total of 320 mils. And if you have an adult size machine and the extracorporeal volume to prime this circuit is about 95 mils, which means that 1/3 of the patient's blood volume is outside the body. So what's that going to lead to? That's going to lead to hemodynamic compromise. And hence we say any child who's less than 10 kilos should have a blood prime. And there are different ways you can blood prime. You can infuse blood into the patient while bleeding patient onto the circuit. You can prime your circuit, your packed red blood cells, which are fresh, which are CPD and comes from the blood bank directly. And the blood bank should know that this is a blood which is going to be used for CRRT priming. You can pre-dialyze your blood to make it physiologic, or you can do a circuit-to-circuit prime. Number one seems to be very easy. We at King's use number two, i.e. we prime our circuit with packed red cells, which are fresh. And of course, as I said, it has to be a preparation which is done when a decision is made that the patient needs to go on CRRT. Of course, it comes with its own risks because your blood bank derived blood can be hypocalcemic, can be acidotic, hyperkalemic, and especially when acidotic blood comes in contact with AN69, that can cause abnormal side effects as well. And this is something which is not published. So please don't tweet or take pictures of this slide. We are just publishing this, looking at the safety and efficacy of CRRT in children less than 10 kilos using standard adult machines. And what we have found is that there were no side effects of the blood priming at all. You can see here, this is the 0 hours. When we started CRRT, this is at 4 hours. You can see there is no hyperkalemia, there is no hypocalcemia. And we have also found that the filter life of newborns who were less than 5 kilos is definitely more than 48 hours. So CRRT done in experienced hands can be better. And then, of course, people talk about your dedicated machines, which could be an adaptation of Aqueduct's machine, which was designed for hemofiltration for adults with heart failures. And you've got this Carpedium machine from Claudio Ronco, which has now been FDA approved in the United States and is being trialed in Cincinnati Children's and now in Rochester. And then you've got the Newcastle machine called the Nidus, which has come from United Kingdom. Coming to blood flow rate, again, very age, weight, access, and hemodynamic dependent. Larger your VASCAT, better are your blood flows, and we aim to have the return pressures less than 200. And what if we have a newborn who is, say, 2 kilos? The newborn will still get 50 mils a minute. We do not go by per kilo here, because we have seen in our previous experience that if we go by per kilo, you will get only 20 mils per kilo if you're using 10 per kilo, and that will lead to frequent circuit clottings. So what we do is we start at 50% of the desired blood flow rate and then go up in steps over the next 1 hour, and we see that the patient tolerates it hemodynamically quite well. And as I said, there's no perfect rates. This is what is recommended, the newborns 8 to 12, but we say that it's vascular access dependent, and we have a set of 50 mils per minute in any size child. And most of the children do not require a blood flow more than 200 mils per minute. The next question is of dialysis fluid and replacement fluid. Yes, we use the same fluid. It used to be lactate-based, now it's bicarbonate-based, and the prescription should include your phosphate and potassium content. The next debate which comes is, should you be using a pre-filter replacement fluid, or should you be using a post-filter? If you look at your pre-filter, the pros and cons, what you do is you're adding your replacement fluid into the blood before it enters the filter. So you're diluting the blood, so less viscosity and more filter life. However, since you're diluting your solutes, you might have a less efficacious treatment. On the other hand, when you're using a post-filter replacement fluid, pure blood is going into the filter. It's more viscous, can lead theoretically to more filter clotting, but it has got a good concentration of solutes, which is not diluted. Therefore, the efficacy of treatment might be better. But what people do is people use a combination of pre and post. Coming to the dose, again, a big debate in pediatrics and adults. The question is about the clearance of a solute. What does it depend upon? It depends upon the dialysis fluid flow rate if it's CVVHD. It depends upon the replacement fluid rate if it is using CVVH, or a combination of the two if you're using CVVHDF. And higher your dose, higher clearance for your toxic molecules, especially in newborns with inborn errors of metabolism, with severe hyperkalemia, and you can remove more middle molecules with CVVH. However, remember, more dose also means more hypophosphatemia, more hypokalemia, more hypomagnesemia, which will also lead to removal of very precious drugs which the patient might require, like your antibiotics. It might lead to more amino acid losses and your more drug clearance, and it will be more, it will be a lot of hard work for your nursing colleagues to change your bags more frequently, and you'll have to give electrolytes more often. So this is just to show what CVVHD and DF look like. This is a 10 kilo child, and if you're giving a dose of 30 mils per kilo per hour, or 2 liters per 1.73 meters square per hour, you're giving 300 mils. If it's pure hemofiltration, this is your dose. If it's pure dialysis, again, the dose remains the same, but everything is going as diffusion. And if you have got a CVVHDF, you are splitting it 50-50. So dialysis is 150 and replacement fluid is 150. But what we need to remember is what you prescribe is not what the patient always get, and there is always a loss. And that loss is normally about 8 mils per kilo per hour for every 35 mils per kilo per hour you prescribe. And this loss is mainly dependent upon your quality and location of your catheter. The catheter is kinking again and again, it's troubleshooting. The machine is starting and stopping. It is not going to give therapy to your patient. If the filter is clogging or clotting time and again, it will depend upon the troubleshooting skills of your staff, and basically everything which causes filter downtimes will reduce what you are delivering to the patient. So therefore, what you desire to prescribe for the patient to get, you need to prescribe definitely more than that. What's the Crt dose? This is a famous paper from Claudio Ronco in the Lancet, and he had randomly assigned 425 ICU patients with acute kidney injury into 20 mils per kilo per hour, 35 and 45 mils per kilo per hour, and the endpoint was survival at 15 days after stopping hemofiltration. And this is the only paper which used pure hemofiltration as the modality. And you can see in the next slide that the survival of patients who received 20 mils per kilo per hour was much lower than the patients who received 35 and 45. There was no difference in 35 and 45. And what they recommended was that the ultrafiltration of the dose should be prescribed according to patient's body weight and should reach at least 35 mils per kilo per hour. Now, this is a slide, this is a portion which shows you patients with sepsis, and the yellow-brown ones are the patients with sepsis, and there is some signal here that the survival, if you have got sepsis, is more if you use 45 mils per kilo per hour, and hence there was a debate on whether high volume hemofiltration should be used in patients with sepsis. Then came these two studies, the acute renal failure trial network study in 2008, and then you had this random evaluation of normal versus augmented level study in 2009, both published in the New England Journal of Medicine, and they did not show that there was any difference in survival whether you use less intense and more intense dose. But again, there are some flaws in both the studies which I'm not going to go into, and therefore you can see that there has been and there will always be a debate unless we use the same modality and do all the patients in the same way. If you have to summarize the CRRT dose, I would say there are lots of factors which contribute to what gets delivered as compared to what gets prescribed. The downsides to high clearance is the cost, dyselectrolytemias, and please make sure that your drugs and your nutrition is kept in mind when you are going up on the dose. If you look at this pediatric CRRT dose, I would say it's a personalized, patient-specific approach. The indication is important, as my colleague previously has said, that center variability is there. So it will have some local variation, and that makes generalization very difficult. We, at the moment, are conducting a European survey from the European Society looking at the variation in practice amongst different centers. And this is what I would say you start off with. You start at 2 liters per 1.73 meters square per hour, 50-50 split of replacement and dialysis fluid, and you can use your dialysis and your replacement fluid interchangeably. Again, coming to something which is very important in pediatrics is how much fluid do you remove from a patient, and is there any evidence for what is safe and what is effective? There is no evidence. The general rule is 1 to 2 mils per kilo per hour in a patient who's hemodynamically stable. Please make sure you count all your ins and all your outs. Your ins include your IV fluids, your nutrition, your calciums, your citrates you're giving, and your outs. Please do not forget the stoma losses, your drain losses, and the diarrheal fluid losses which the patient is having. So based on the hemodynamics and the total severity of your fluid overload, you need to decide as to when you start to remove fluids and how much fluid would you want to remove. And this is an example of a 20-kilo child who is 5 liters positive, gives you a 25% fluid overload, and you need to remove 5 liters. And you just can't remove fluids of 5 liters. It has to be done step by step. And you need to make sure that right at the start of the shift in the morning, as a team, when you're going around, you say, right, I think we should aim, the patient is not hemodynamically stable, the inotropes are not going up, you're not giving fluid boluses to this child, time to start removing fluids. And if you are removing fluids, let's aim for a negative of, say, 400 mils in the next 24 hours. And every so often, check your bed with your bedside nurse. How is that fluid being removed? Are you being able to remove the fluid boluses or your blood products which you're giving to a child? So very important to have an ongoing communication with your bedside nurse and setting the targets and seeing whether those targets are met or not. Anticoagulation, one of the biggest challenges in pediatrics. And as I said, you might have the funkiest of machines, but if your circuit is clotting time and again, it's not going to do any good. There will be more downtimes and your prescribed dose will not be delivered. And therefore, after you have optimized your circuit factors and your patient factors, it's time to think about anticoagulation, which is selectively active in the circuit but does not cause problems to the systemic circulation or systemic coagulation of the patient. The factors which lead to premature clotting could be patient-related, access, circuit, or treatment-related. For example, if a child who's got sepsis or acute liver failure, they might be prothrombotic. So you might have to use higher than normal doses of anticoagulation, but please make sure that the staff who are going to run the show, the shop floor, are well trained in the protocols. You shouldn't just go for a conference and say, right, this particular gentleman on the stage said, I want to use X uh, uh, dose of a particular anticoagulant and we should use that. You need to make sure that your whole staff is well trained to identify what the side effects of that particular anticoagulant is. And we need to know what the monitoring technique is used for the efficacy of that treatment. So the points to consider while choosing an anticoagulation is which anticoagulant, what dose, and what is the route of delivery. Are you going to give it systemically? Are you going to give it regionally? Or are you going to combine it? So this is just a list of anticoagulants which are available. The most commonly used are heparin, low molecular weight heparin, citrate, and prostacyclin. We at King's do not ever not use an anticoagulant. Most of the times we are able to use prostacyclin because that is our standard protocol for our patients with both liver and non-liver diseases, though heparin is the most commonly used because people have got large experience in it. It has got a short biological half-life, but you need to be aware of its side effects, which is heparin-induced thrombocytopenia, bleeding, and unpredictable pharmacokinetics. This is citrate. Citrate goes into the patient after the blood comes out, but pre-filter, and then you give the calcium into the patient directly without going through the filter. And that causes hypocalcemia within that inhibits your coagulation. And this is our protocol of prostacyclin. As we said, we are an exclusively prostacyclin using unit. We start at 4 nanograms per kilo per minute, and we gradually go up to 8 nanograms per kilo per minute. And here you can have our protocol, which is on pcrt.com/protocols. And if we are running into trouble with frequent filter clotting, we then combine the two. You can see here's a 3-way tap. Here's a heparin at 10 units per kilo per hour, and here's prostacyclin at 4 nanograms per kilo per minute. We have a patient just now on the unit whose filter clotting was like literally every 4, 6, 7 hours, and the ACT was 120. The moment we combined heparin and prostacyclin, the ACT immediately went up to 170. We aim for 180 to 220, and that's how you can make your circuit survive. So this is just a summary of your anticoagulation. Please make sure you understand your protocol. The nursing staff, the physicians and nurses should know about the potential complications. And again, advanced planning and careful monitoring will help limit the problems. So if you start with a standard prescription, a blood flow rate, which is at least 50 mils per minute for a newborn, and you can go up based on the weight and the size of the patient. Choose a membrane surface area proportional to the patient's surface area. Decide you're going to give convection, diffusion, or a combination of the two at 2 to 3 liters per 1.73 meters square per hour. Again, depends upon your local policy. For example, we at King's always start with CVVH first, and if things don't work, for example, if hyperammonemia is not coming under control, we might then move on to CVVHD or CVVHDF. Increase your solution exposure per unit of time, and $1 million thing, please keep your filter downtimes minimized. It's very important for things like acute liver failure with hyperammonemia, for example, because you're just not giving CRRT to remove fluids here. You're giving it because your brain is swollen because of hyperammonemia, and hence you need to make sure the downtimes are minimized. This is a prescription for your 4-kilo baby. First of all, what is the indication? Whether it's AKI, fluid overload, space for nutrition, etc. Your VASCAT size will be about 6.5 or 7 French. What is the CRRT type? CVVH. Priming methods, a 4-kilo child, we have to give a blood prime. Your blood flow rate will be 50 mils per minute. Solution type will be this. Your clearance, you start with 2 to 3 liters. You decide about the ultrafiltration removal rates. Make sure you give a lot of importance to nutrition here and adjust your drug doses based on the dose. So as we know that CRRT prescription can be done meticulously, but the CRRT membrane is non-selective. It will remove your goods as well as the bads. So if you prescribe without consideration of nutritional needs and medication requirements, it will put your patient at a risk for poor outcomes. both the micro and macronutrients will be removed, including the proteins, trace elements, and that will require very careful consideration. And the drug removal in CRRT depends upon all these things, and therefore you need to contact your pharmacist. You need to have a reference guide to say which drugs will require adjustment of dose. Now, whether it is to do with just spacing them out or decreasing the dose, but again, you need to have a reference point for it. Nutrition, as I said, very, very important. Make sure that you adjust your proteins. At least 1 to 1.5 is pre-CRRT, and people go up to 2.5 grams per kilo per day if you are on CRRT. And this is a concept of dilate trauma. Again, you need to bear in mind that nothing comes without a cost. CRRT has gained importance and people use it, but remember there is a concept of dilate trauma, which means all the harmful adverse effects related to CRRT, which includes your vascular related side effects, your anticoagulation related side effects, and your modality, and the non-selective transport of molecules to the membranes need to be borne in mind. And therefore, you need to have a checklist which tells you what are you doing daily and what are the side effects. And this particular modality, you can see that here's the center is your patient, and you've got lots of specialties which run around a patient to make CRRT happen, whether it's a dialysis team, the Crt care team, nephrologists, pharmacists, dietitians, and the laboratories. They all work together to make this particular modality take place. And again, when you talk about quality indicators, we can't just run a program without knowing how are we doing. So we need to choose the quality indicators applicable to our program, and that should reflect the delivery and the coordination of care. It should be independent of patient outcomes, and ideally there needs to be benchmarking of data. And this is a paper from my colleague Teresa Marks from Cincinnati Children's. And as you can see, when the patient gets admitted to the ICU here, they look at various outcome measures which are related to filter life, which also looks at how much are you delivering based on how much are you prescribing. So initiation, maintenance of the patient, and efficacy of the delivery of CRRT, very, very important. And then they look at the outcome measures, which are renal related, which means looking at the renal recovery, the morbidity and mortality. So if you have to start a program, just make sure you have at least 2-3 benchmarking stuff. For example, we say all our filters should last at least more than 48 hours. Now, I'm sure in adults that might not be a problem because their benchmarking might say 72 hours, but we in pediatrics try and aim at least for 48 hours. So in conclusion, there's been a huge progress in the field of pediatric critical care nephrology with regards to technology and modalities. The main pediatric challenge remains differing weights, differing sizes, and one size, i.e. one protocol will not fit all. There will be a protocol for different vascular access based on different sizes, similarly different hemofilters and sets. You might have to have a separate protocol for blood priming, and as it has got different techniques as well. And what we have shown is if there's an experienced team and there's a well cohesive team working together, you can achieve CRRT even in children less than 5 kilos using standard adult machines like PrismaFlex, for example, and we have not experienced any issues. This is the section I was talking about, the critical care nephrology section of the European Society. We started off as a baby section about 6 years back, and now we are one of the most heavily subscribed sections. So if any one of you is interested in joining the section of ESPNIC, please do write to us, and we'll be very keen and interested to have you on board. And this is a resource which my colleague Stuart Goldston from Cincinnati and myself put together about a couple of years back. It's available online as well as a hard copy. And we are having a masterclass on continuous renal replacement therapy on the 15th of June. This is by the critical care nephrology section of ESPNIC. If any one of you want to subscribe, this is the program, and these are the speakers for the program. With this, I thank you for your attention and thank you for your time.
Thank you, Professor Deep, because you are actually a reader that's associate professor in the new universities, but in the old universities reader. We have actually run over time, but I think you have given an excellent presentation, essentially condensed master course in pediatric CRT. There are many questions in the chat, and we will send all the questions to each of you, depending on which one is involved. But I think I will just give one question to each of you. So first to Dr. Sarah Blakely, and I'll condense two questions into one. Your preference for membranous TPE versus centrifugal TPE, and comment on the cost effectiveness of each in the center. And of course, there are other questions which we'll send to you later on.
Of course. I think some of the cost effectiveness is going to depend on what you are already set up for. If you already have a machine that is capable of delivering continuous renal replacement therapy and plasma exchange, then you have the machine. Your biggest cost after that is then going to be buying the filter cartridge, and they are typically more expensive than standard CRRT filter cartridges. With centrifugal plasma exchange, the machine, if you don't have the machine, then obviously you would have to buy one. So if you already have it, then you don't have that cost. You don't have to use an individual cartridge for it. The other consumables are a lot cheaper for centrifugal. So if you were starting from scratch, then it potentially would be cheaper to go for centrifugal plasma exchange. However, what you then also need to factor in is where your greatest cost is going to be. Is it your consumables, your machine and your filter, or is it actually the replacement fluid? And if you, the cost of albumin, the cost of plasma, those things need to be factored in as well. So it really does depend. If you are starting from scratch, then perhaps centrifugal therapy might be more cost effective. And as I say, there is no evidence to suggest that one is better than the other, but you would need to also make sure that your staff are trained in it. So slightly avoiding the question, but it does depend on what you already have. Probably membrane is more expensive, but if you're having to give renal replacement therapy to your patients anyway, you would have to have that machine. So a lot of the cost does come down to replacement fluid. I hope that slightly answers some of the question.
Yes, thank you very much. And we'll send the other questions posed in the chat to your lecture separately in the email. And Dr. Deep, thank you very much. It's really a very nice master course in pediatric CRT. There are many questions, so I'll try to combine two into one. Can you comment on catheters in neonates inserting into the internal jugular? Number one. Number two is there's an old saying from one of the physicians saying that the surface area of a hemofilter should be smaller than the surface area of the child. I'm combining two questions into one because there are many questions in the chat box.
Right. So first question about choosing a vascular access, as I said, is that people always worry about clotting of these filters and catheters, and therefore what is available in the UK, the minimum size is 6.5 French. And the reason we go for internal jugular and not the femoral in newborns is when they are on the ventilator and they are well sedated, it's not a problem. The moment they wake up and they actually bend their groin, that's when everything is going to go haywire. So we choose this, we use an ultrasound, we measure the size of the vein, and then we go in, and after giving the blood products, especially because we are a liver center at King's, we get a lot of patients with acute liver failure, newborns as well. So we use 6.5 French, 8 centimeters or 10 centimeters. But as I said, the problem is it hangs outside, because if you put it deep down, it's going to cross the valve and go somewhere else. So we actually have to leave about 2 to 3 centimeters outside, and that might sometimes become either an infection risk or that the catheter is kinking, or so we just have to keep a close eye on that. And again, I completely agree that he is dependent upon the size of the baby, whether it's a small baby, whether it's a child, or whether it's an adolescent. Anyone who is more than 40 kilos, for example, will get an adult set. We do not have a pediatric set for them. We use an adult set for them. And if you have a newborn, you get a mini set. If you have got a child between, I would say, 10 kilos and 40 kilos, we have a separate set for them.
Okay. So I think we are actually over time. On behalf of Baxter Asia and on behalf of the almost 200 people who have called in, I'd like to thank, first of all, Dr. Blakely for her excellent lecture, and also Professor Deep for his excellent lecture also, which basically is a very concise overview of Pediatric CRT. Anil, my marketing colleague, maybe you have some comments about video on demand or whatever.
No, thank you, John. And I think you said it right. It was first of all a very comprehensive one came in from Dr. Sarah, and help us understood very nicely the two different modalities in terms of the membrane and centrifugal. So I think we could able to understand clinically that how physician looks at it, which is fantastic. Also, the indication that she has posted for various neurological or other indications that she posted. And then I think, John, you said it rightly. It was a comprehensive crash course, I would say, came in from Dr. Deep. I learned it a lot again myself, and I'm sure the audience too. So thank you so much, Deep, once again, for giving us the broader view after how this special population need to be looked after. So with that, I also thank you on behalf of Baxter for coming and presenting these two specific subjects for us. Thanks a lot.
Yeah, I'd like to thank everyone who has attended, and particularly those who have given the questions. I will send the questions to the respective speakers individually, and you'll respond to them. And for doctors who want to review the presentation, we will please ask your Baxter staff, and they'll provide a link for the video that was recorded. Bear in mind that Dr. Deep has some unpublished data, so please do not reproduce them in any way, shape, or form. And it's very nice to actually share with us his unpublished data, which I'm sure will be published very soon this year. And Dr. Sarah, I'm sure you enjoyed the view in Portsmouth. I saw YouTube where Queen Elizabeth visited her flagship HMS Queen Elizabeth. So I'm sure you have a very nice view of the Royal Navy. And Portsmouth, by the way, is the only island city recognized in the UK. And Prof. Deep, thanks again. I know that you have a very active liver transplant center, and you get a lot of children with biliary atresia. So yeah, I'm also very interested in liver transplant because I used to do the portal artery for the adult child donors. So on behalf of Baxter Asia, I'd like to thank our speakers, Anil, our vendor, and everyone who has attended, and particularly those who have posed the questions. Rest assured that we will respond to, we will send the questions to the speakers and they will respond accordingly. So thank you very much and have a great evening. And for those in England, we have some people call in actually from the United States, by the way. I'm not sure why, but we, so, basically, the status of our webinars and the speakers are well respected. So thank you very much.
Thank you very much.
Okay. So
Thanks for having us.
Thank you very much. Thank you.
Okay.
Thank you.
Okay, Ning, we may lift. Yeah.